This is Tyler Cobbs, and I'll be presenting my journal club article that is norfloxacin versus ceftriaxone and the prophylaxis of infections in patients with advanced cirrhosis and hemorrhage. So starting off, we'll talk kind of about the purpose of the study. In 1992, there was a trial that demonstrated that norfloxacin reduced the incidence of bacterial infections, and it was also associated with improved survival amongst cirrhotic patients with a GI bleed. Furthermore, there have been epidemiology studies that have showed a change in antimicrobial resistance patterns with an increase in quinolone-resistant bacteria causing infections within these patients. This randomized controlled trial was aimed to compare oral norfloxacin versus IV ceftriaxone and the prophylaxis of bacterial infections in cirrhotic patients with a GI bleed. So to go over the design of the study, it was a multi-centered, double-blind, parallel group randomized control trial. Total participants in the study was 111, with 54 in the IV ceftriaxone group and 57 in the oral norfloxacin group. This took place in Spain in 4 different hospitals, and the study duration was over 4 years. The analysis was intention to treat, with the endpoint of the trial being the prevention of bacterial infections within 10 days after inclusion. Primary outcome being proven infections plus possible infections, and we'll go over how they classified those two things. So the inclusion criteria were pretty stringent in terms of the 2 or more signs of advanced cirrhosis, being the severe malnutrition with muscle wasting, bilirubin greater than 3, ascites confirmed by paracentesis, and hepatic encephalopathy. This led to most of the participants who were screened not to be included in the study. Other inclusion criteria were ages 18 to 80 and hematemesis or melena within 24 hours. Exclusion criteria were allergy to one of the 2 study agents, infection signs, which you can see there, antibiotics within 2 weeks of the hemorrhage, prior hepatocellular carcinoma, and HIV patients were also excluded. Antibiotics were initiated within 12 hours of admission. Antibiotic administration randomized with one group receiving 1 gram of ceftriaxone IV Q24 hours and the second group receiving norfloxacin 400 milligrams by mouth twice daily for 7 days in each study arm. Each day, they performed a physical examination and blood cell count. They did a urinary sediment every 48 hours, chest x-ray every 3 days for the 10 days, and also blood, ascitic fluid, and urine cultures were taken whenever a patient developed signs of infection. So these are kind of our 2 endpoints, proved infection and possible infection. So for proved infection, they did spontaneous bacteremia, obviously, spontaneous bacterial peritonitis, and they used a polymorphonuclear cell count equal to or greater than 250. Urinary tract infection with a leukocyte count greater than 15 cells per high power field and a positive urine culture. Other infections were diagnosed according to clinical, radiologic, and bacteriologic data. The possible infections, this is where it gets a little bit tricky. They saw patients with fever greater than 37.5 for more than 6 hours, leukocytosis of greater than 15,000, or an increased concentration of immature neutrophils in the blood, greater than 500, negative cultures, and no other signs of infection. So the analysis was performed separating these into 3 groups, with patients not developing infections, patients developing proved infections, and then the patients developing proved or possible infections. So the third one's kind of the cumulative. 1,369 patients were screened, with screening failure occurring in 1,245. Of these, like we mentioned earlier, the 2 or more signs of advanced cirrhosis was what eliminated most of the people from the study. This excluded over 800 of the 1,300 that were screened. These 124 patients that met all inclusion criteria were randomized with 63 and 61 in each group. There were inclusion errors including just occult infection and then violation of protocol. Again, those 4 and 3 were not showing 2 signs of advanced cirrhosis. So we ended up with 57 in the norfloxacin group and 54 in the ceftriaxone group. So here are the first 2 tables. We'll kind of go over the main points. It just went over the kind of key clinical data in each group. Each were comparatively similar, going from age to the sex. Alcohol cirrhosis did show a statistically significant difference, with 57% in the ceftriaxone group and 77% in the norfloxacin group. Another that showed significant difference was the renal failure percentage, and they classified this as a serum creatinine of greater than 1.5. There were 19 patients with renal failure, 19% of patients with renal failure in the ceftriaxone group, and only 5% of patients in the norfloxacin group. As you can see, everything else, including the child-Pugh, MELD, bilirubin, percent of ascites, and other data was pretty similar and not statistically significant in difference. So we move on to table 2 that show the characteristic of hemorrhage at inclusion and course of bleeding. Again, very similar amongst both groups. One thing that I kind of wanted to point out is was the source of bleeding. Esophageal varices accounted for most of the bleeding, with 61% in the ceftriaxone group versus 67% in the norfloxacin group. Again, the difference was not statistically significant. Our next table is kind of what the study wanted to find out was, were there a difference in the percent of infections or possible infections between the 2 groups? The patients with proved or possible infections in the ceftriaxone group was 6. All of these were just the proved infections with no possible infections. And then in the norfloxacin group, you have 19 with proved or possible and 15 with approved infection. The p-value with the proved infection was 0.07, but 0.01 in the proved or possible, with the 19 included. Another thing that I think should be mentioned is the organisms. This study was designed based to find the difference and see if one of these antibiotics was more efficacious than the other, especially given the change in epidemiology with gram-negative organisms and quinolone resistance. You can see that the gram-negative bacilli that are fermentative, there were 6 in the norfloxacin group and 0 in the ceftriaxone group, which was statistically significant. So to go over the results, a Cox regression analysis identified the following as independent predictors for proved infection. So their number 1 independent predictor was norfloxacin prophylaxis. This showed a hazard ratio of 3.21, and we'll get into what a hazard ratio tells us on the next slide, with a confidence interval of 1.24 to 8.32, and a p-value of less than 0.02. Blood transfusion requirements and mean arterial pressure at inclusion were also considered independent predictors for proved infection. Primary outcomes were 11% in the ceftriaxone group versus 33% in the norfloxacin group. And then to go over secondary outcomes, one thing I wanted to point out was the 10-day mortality was 11% versus 9%, and statistically non-significant, but we'll kind of get into what that means here in a second. Going back to hazard ratios, so hazard ratio is a comparison of the probability of events in a treatment group compared to the probability of events in a control group. Here we have 2 treatment groups, but this doesn't change anything. A hazard ratio of 1 means that both groups, the treatment and control, or both treatment groups in this case, are experiencing an equal number of events at any point in time. A lot of times it's easy to confuse relative risk versus hazard ratio, but the relative risk and odds ratio, those are cumulative over an entire study using a defined endpoint, where a hazard ratio tells you your point of an event occurring at any point in time during the study. So the patients in the norfloxacin group were a little more than 3 times as likely at any point in time over the 10 days to get an infection compared to the ceftriaxone group. And at the bottom, that's the formula. I don't know what all that means, but the T is the important part, and that's the time, really. And that's what really separates hazard ratio from a relative risk. So conclusions, the IV ceftriaxone was more effective than oral norfloxacin in the prophylaxis of bacterial infections in patients with advanced cirrhosis and hemorrhage. And there's some cool organic chemistry, and that's ceftriaxone. I think that's what the internet told me. We'll go over criticisms of this study. PO versus IV antibiotics. The oral route's just probably not adequate to treat patients with active GI bleeding, vomiting, and submitted to periodic aspiration. A lot of these patients had an NG tube in, from my understanding. They didn't give an exact percentage, with extremely rapid intestinal transit as well from the bleed. Also, this study was not adequately powered to calculate mortality. We kind of touched on the mortality rate, 9 versus 11, I believe, that was not statistically significant. But then again, this study was not powered to calculate mortality. Additionally, 2010 Cochrane review did not find benefit of one antibiotic over the other, and therefore recommended antibiotic choice based on local sensitivities. I don't know if I mentioned it, but this study was published in 2006. So this Cochrane review was done right about four years afterwards. That sums everything up. Here are my references. Moving on, we got pictures.
Can I take that dog? No. Can I take that dog? No, he's sleeping.
So those are my 2 dogs. Jorah on the left and Django's on the right. And then the biggest Dallas Stars hockey fan in the world, that's Rachel. She's betrayed her Boston roots and is a converted Texan now. Discussion.
So very good, Dr. Cobbs. I appreciate that. I appreciate the effort you spent looking into getting those gifts of dogs and little boys wanting to pet them. I'm going to give kind of a Cliff Notes Idiot's Guide version of where we've been with the idea of antibiotics in people with cirrhosis and active GI bleeds. We've known, well, where we are now, the SLD has their guidelines from only 2007 that touch on this. And their guidelines are that for people with cirrhosis and upper GI bleeds, they recommend antibiotic prophylaxis. Their recommendations back in 2007 focus on utilizing norfloxacin or an oral quinolone over an IV ceftriaxone, even with the data that they currently had. Moving forward, we've only had really one other guideline from the World Gastroenterology Organization in 2008, I believe, that mirrored those recommendations as well. So not a lot of movement in guideline production on this topic in the last 10 to 15 years. There was a meta-analysis done. Dr. Cobbs touched on the Cochrane review done in 2010. There was a meta-analysis done in 2012 that demonstrated improvement in mortality, bacterial infections, and rebleeding by utilizing antibiotics in prophylactic form for these patients. And that's taken about 10 different studies done since 1985 that have been accomplished on this topic. And so if we go backwards in time, the first study that demonstrated benefit for antibiotics in this cohort of patients was in 1985, utilized norfloxacin. I'm sorry, they utilized a very weird regimen of non-absorbable antibiotics, which were either vancomycin, gentamicin, nystatin, or colistin, neomycin, and nystatin. So that was extrapolated upon in 1992 by a group that looked at norfloxacin, which showed benefit, as Dr. Cobbs touched on. A subsequent analysis done in 1998 looked at IV ciprofloxacin versus none. And both of those studies, the 92 study and the 98 study, showed about a 10% infection rate in those treated with antibiotics versus about a 35 to 40% infection rate for those not treated with antibiotics prophylactically, just to give you kind of a reference point. So this study, I think, was good. It demonstrates what we have found in that infections and GI bleeds and cirrhotics go hand in hand. We still don't understand if the bleeding causes infection or if the infection causes bleeding. We know that in people with cirrhosis, their complement levels are reduced. We know that they have increased translocation of bacteria. We know that in infections and bacteremia, endotoxins cause increased translocation within the bloodstream. They cause blood vessel wall degradation. So we still don't actually know which came first, but we do have enough data to support the idea of treating with antibiotics prophylactically as soon as they come into the hospital. So Rocephin, through several other studies, has been demonstrated to be more efficacious in people who have Child-Pugh class B and C liver failure or cirrhosis. In these patients, we found that there's an increased level of quinolone-resistant organisms. The four main ones that we look at are E. coli, Enterococcus, Pseudomonas, and Klebsiella. So long story short, the study itself helped kind of push the needle a little bit in the utilization of ceftriaxone as a very good agent for patients who are either high-grade cirrhosis or in those who have a quinolone allergy or have a quinolone-resistant bug. And that's where I think the majority of the clinical relevance of this study comes from. What we do in the hospital, someone comes in with liver failure and a GI bleed, we generally start them on Rocephin. For a lot of reasons, we could utilize you could utilize Cipro in an IV form, but these patients are NPO and we need to have an IV version. We're not going to be putting NG tubes in someone with varices or no known history of cirrhosis that has a high risk of varices. So generally, ceftriaxone. The prophylaxis course is 7 days, and generally, if somebody is coming in and they're going to be discharged home, we switch them over to ciprofloxacin to finish out the 7-day course. So that's what we do clinically, and this study from 2006 helps in guiding that principle.
Dr. Connell here, just a couple of comments on some of the statistical analysis. So Dr. Cobbs actually explained hazard ratio really well, but I just want to touch a little bit more on it because I think it's important for us to understand when a study gives us a number, what does that number actually mean? So the hazard ratio is this time point where a relative risk or an odds ratio is cumulative, which Dr. Cobbs talked on. So if you look at the hazard ratio, it's statistically significant for norfloxacin as a predictor at 3.21. So that means at any given time point, somebody has a 321% more likely risk of, developing an infection at any given time, but that's not cumulative. And you can tell that that's not cumulative because if you look over at the graphs at the 10-day follow-up, Rocephin did better, but you don't see a huge split. It was 11% versus 33%. And then the graphs, yes, it looks just a little bit less dramatic of 300%. And so just keep in mind that when you're looking at those numbers, the media may throw out big numbers like a hazard ratio of 3.21%. But we also want to think about the cumulative risk overall. In this case, Rocephin has come out on top for multiple different reasons. But just understanding what those numbers mean and when it says this is a hazard ratio or this is an odds ratio is important. I think Dr. Cobbs did a great job explaining it, but just making sure you understand those numbers.